How's it going, guys? We have a medium difficulty question for cardio. 67-year-old man brought in by ambulance. Blood pressure is low at 90 on 60. He's got tachycardia 112 to tachypnea, respiratory rate of 20. They've got this very recondite, obscure graph here showing you arterial pressure on the y-axis, time on the x-axis, but you can see that there's a drop of blood pressure greater than 10 millimeters of mercury with inspiration. This is called pulsus paradoxus, which on USMLE you're going to see with cardiac tamponade. Can you see it sometimes, rarely with other things such as severe asthma? The answer is yes, but on USMLE you're going to see it with tamponade. Okay, now tamponade, you're going to have Beck triad, hypotension, JVD, muffled / distant heart sounds, and sometimes they can mention the pulsus paradoxus in the question. Something you got to know for USMLE. Okay, so we didn't give you overt Beck triad here. We didn't need to. We were intentionally vague, but holy shit, showing you this arcane graph here. Right, so pulsus paradoxus. Now, what are we going to see on ECG with cardiac tamponade? Which, by the way, cardiac tamponade equals pericardial effusion plus low blood pressure. We said Beck triad, hypotension, JVD, muffled distant heart sounds fine, but a tamponade equals pericardial effusion plus low blood pressure. Now, it's the rate at which the fluid accumulates that determines whether you have a tamponade or not the volume. So you can have a stab wound to the chest, you can have left ventricular free wall rupture secondary to MI, and have acute low volume accumulation of blood in the pericardial sac that leads to tamponade. You could have a very large volume, let's say chylous accumulation due to lymphoma over many months that doesn't lead to tamponade. So it's the rate of accumulation that matters. So what are we going to see? Choice A, diffuse ST segment elevations is wrong. That's pericarditis. So that's going to be, can be serious pericarditis where you have cocaine use, 22-year-old male after a night of heavy partying, pain in the chest that's worse when he leans back, better when he leans forward. Can be autoimmune diseases such as SLE, RA. USMLE really likes that for pericarditis. It can be things like viral infection. Okay, it doesn't have to be Coxsackie B, but Coxsackie B is notorious for causing cardiac issues like dilated cardiomyopathy, sometimes pericarditis. You can have fibrinous pericarditis, so uremia, uremic pericarditis, or high BUN and creatinine, you have a friction rub. It can be post-MI fibrinous pericarditis within days of an MI. It can also be weeks after an MI called Dressler syndrome, another type of fibrinous pericarditis that's antibody-mediated. You're going to have diffuse ST segment elevations, and you're going to give an NSAID first as treatment usually. There's nuances. Usually after an MI, you'll give aspirin, not simply indomethacin ibuprofen, but in general, NSAID first, colchicine, then steroids, similar to acute gout treatment. Wrong fucking answer. Choice B, electrical alternance, low voltage QRS is correct answer. This is what we see with both simple pericardial effusion as well as tamponade, and it's because we've got fluctuation of the fluid over the pericardium, or within the pericardial layers, serous pericardium, the parietal and visceral layers, that the electrical signal will be read at different amplitudes. Okay, so if they show you an ECG and they do this twice on the new 2CK NVMEs, they expect you to know that if you have very low amplitude above and below the x-axis for the leads, and also slight fluctuations, electrical alternans with low voltage QRSs. So they want you to know that for both simple pericardial effusions as well as tamponade. So let's just whip through the other ones. Peak 2A is wrong. That's hyperkalemia. Flattened T waves or U waves, hypokalemia. The point you got to know for USMLE is that if you have ECG changes in the setting of hyperkalemia, that they want IV calcium gluconate or calcium chloride as the next best step. It stabilizes the myocardium in the setting of hyperkalemia. Wrong fucking answer. Choice DST elevations 2-3 AVF for inferior infarct is wrong. Okay, so the diaphragmatic surface, the inferior surface of the heart, is supplied by the right coronary artery usually. So it's going to be the posterior descending artery that supplies the diaphragmatic surface of the heart. Don't confuse with the apex of the heart, which is the left anterior descending artery. But the PDA supplies the diaphragmatic surface, and that's going to be coming off the right coronary in 80 to 85+% of people. It's called right dominant circulation. So if they don't specify, they just give you 2-3 AVF MI, the answer can be right coronary artery. It can be PDA. If they tell you it's left dominant circulation, if they explicate that, the sequence they want on USMLE is left main coronary goes to circumflex, goes to PDA. Wrong fucking answer. Choice C, S1Q3T3, wrong fucking answer. Okay, it's an obscurity that apparently is highly specific for pulmonary embolism, but it's wrong on USMLE because the most common finding on ECG in pulmonary embolism is simply sinus tachycardia. Okay, so S1Q3T3, smaller percentage of PE cases, but students will jump on it. Okay, they'll memorize obscure stuff. So they can just give you a patient, let's say, had surgery, you get a DVT, and they've got acute onset shortness of breath, tachycardia, or they'll tell you patient has acute onset shortness of breath, ECG shows sinus rhythm, and then they'll tell you the heart rate is 100. That's sinus tachycardia. That's what you're going to see in pulmonary embolism, sinus tachycardia, but S1Q3T3, some fancy obscurity that's wrong for USMLE. In this case, wrong fucking answer.